Dr. Stephen Paget. I'm Physician-in-Chief at Hospital for Special Surgery. And it's a pleasure to introduce to you Dr. Thomas Lehman, who's a professor of clinical pediatrics at the Weill Medical College of Cornell University, and an internationally recognized specialist in the area of pediatric autoimmune and rheumatologic disorders. Dr. Lehman, what proportion of children develop arthritis or other types of musculoskeletal problems?
Arthritis is actually relatively common in childhood. It's about 2 per 1,000 in any given year. Musculoskeletal problems are extremely common. Probably 10 or 20 people, 20 children per 100 have some kind of significant musculoskeletal complaint over any given year. In most of them, it's minor injuries, minor overuse in athletics, and with some gentle reassurance and appropriate education, the problem resolves. For children with arthritis, however, they need good care. Too many of the children who have arthritis are dismissed as simply being an overuse injury or a muscular problem, and then they don't get the proper care. In childhood, as the body's growing, if something like arthritis is allowed to go on undetected or improperly treated, then it produces permanent problems that can last well into adulthood.
What are the typical symptoms or complaints that a child or their parent may have as they go to their primary care pediatrician?
Often parents go to the doctor and they say, you know, he seems to be limping or he looks a little stiff when he wakes up in the morning. And because children with arthritis frequently have morning stiffness that resolves over a period of time, the pediatrician will examine the child quickly, not recognize the child's limitation of motion, say everything looks fine to me, must be growing pains, and dismiss it. But children should never have growing pains during the day. Growing pains are a nighttime phenomenon, sometimes wake the child up in the middle of the night, but when that child wakes up in the morning, he should be fine. If he isn't fine when he wakes up in the morning, it's not growing pains.
What are the more typical types of medical problems and joint problems that a child would have? And are they differentiated with regard to age?
Children with arthritis have a large variety of conditions. Although we used to talk about juvenile rheumatoid arthritis to refer to any child under the age of 16 with arthritis, we now know there's a good 15 or 20 different conditions that cause arthritis in childhood. Some, like quote-unquote post-articular juvenile arthritis, frequently start in young children, little boys, little girls, with a swollen knee who often just seem stiff or don't walk right when they first get up in the morning, but they're fine later. And often it takes a number of months before the parents realize there's really a problem or someone points out your child's knee is swollen. Other children are the older children who often are coming in, and when I see them, they've been told they're clumsy. They've had multiple sprained ankles or multiple injuries, and it's just because they're bad athletes or they don't loosen up enough. And they have one of the spondyloarthropathies. When you recognize the diagnosis, give them an appropriate treatment, they feel much better and they do much better. Throughout the whole spectrum of rheumatic disease, each age group has its most common presentations, its most common diseases, and each of those has a different outcome and a different best treatment.
What should the primary care pediatrician do in their practice on a regular basis to make sure that they don't miss these problems?
The most important thing for primary care pediatricians is listen to mothers. We don't expect the primary care pediatrician to understand all of the differential diagnosis of the childhood rheumatic disease, and we don't need them to know which one it is. But if the mother's coming in and saying, my child doesn't walk right in the morning or my child has a problem, the primary care pediatrician shouldn't be dismissing it as growing pains without a proper evaluation. If that mother's come to you and mentioned pain in the child's joints more than once, that child should be referred to a rheumatologist so that somebody can properly reassure the mother there isn't a problem, or properly diagnose what is going on so it can be properly taken care of.
What are some other danger signs that the mother and the pediatrician should keep in mind?
I think pain and stiffness are the two biggest ones. Pain during the day, children don't normally complain. They don't complain of back pain, they don't complain of knee pain unless something's going on. Stiffness, there's no good reason a child should be stiff when he wakes up in the morning or walk funny when he wakes up in the morning unless he has an underlying condition. Physicians and parents need to be attentive to these kinds of problems and make sure children with these problems are appropriately treated.
What about other symptoms such as fever, weight loss, failure to thrive?
When you see children, especially the older child, you have to be very concerned about what I call adolescent failure to thrive, the child who's not doing well, the child who's been losing weight, the child who's losing interest in school, the child who's had rashes or fevers or night sweats. Those can be symptoms of many different chronic diseases. The rheumatic diseases such as lupus, scleroderma, dermatomyositis, all may start with those conditions. So could tuberculosis, leukemia, Hodgkin's disease. A child who's failing to thrive for whatever reason in that older age group should be referred to an appropriate specialist for a complete diagnostic workup.
Why is it important to make a diagnosis as early as possible?
In every one of the childhood rheumatic diseases, it doesn't just go away. They don't just grow out of it. There's a small proportion of young children with pauciarticular JRA who do, in fact, get well. All the other rheumatic diseases progressively cause problems over time. The sooner you recognize the disease, the faster you can start appropriate therapy, put that fire out, prevent damage from being done, and prevent continuing problems from occurring.
Let's take a few specific disorders, and if you could give me your approach, your diagnostic and clinical and therapeutic approach. What's called juvenile rheumatoid arthritis.
Okay. First thing to understand is that juvenile rheumatoid arthritis doesn't exist anymore. We now have juvenile inflammatory arthritis. The reason is that juvenile rheumatoid arthritis has nothing to do with rheumatoid arthritis in adults, is not rheumatoid factor positive. It should be rheumatoid factor negative. So it's a different disease. So it's juvenile idiopathic or juvenile inflammatory arthritis. Within that, there are a number of different conditions. If you take a young child who's stiff when she wakes up in the morning, has a sore knee, that child probably has typical pauciarticular JIA now. With appropriate therapy, we can prevent her from having leg length discrepancies, which can come from uncontrolled inflammation. We can prevent her from developing contractures and get her back as a fully functional young adult and young child at that point. More importantly, many of these children have painless and unsuspected eye disease. If that eye disease is picked up early when they're referred to an ophthalmologist and properly diagnosed, we can fix their vision. If that goes undiagnosed for a prolonged period of time, these children can end up blind. We need to catch these children, we need to figure out what's going on, and we need to get them appropriately taken care of. In the older child, I frequently see children with what I call dactylitis, or a sausage digit, one big swollen finger. People think, well, she recurrently stubs her finger, or sometimes it's a toe. She must recurrently stub her toe, or he. Okay, or maybe it's always basketball injury. They're chronically doing it. These children often, when you examine them, have arthritis in multiple joints that everybody's been dismissing. This is a chronic form of arthritis that's going to cause significant disability in adult life if it's not detected. Once you detect the disease, you can get the child on appropriate disease-modifying agents, and instead of having somebody who goes up to a lifelong complaints of, yeah, I've always had back problems, and yeah, my knees are bad, I must have played too much football, or I must have done something skiing, you restore them to good health, get their strength back, and you can make sure they grow up to be good, functional adults. With proper care today, the vast majority of my patients will walk right past you on the street, and you won't realize that they're children who've had arthritis. In the old days, you used to walk into juvenile rheumatology clinic, and there'd be kids in wheelchairs. We don't have wheelchairs anymore. Proper care keeps these children mobile, productive members of the society, out there working, out there having their own families, fully functional individuals that you don't see.
You mentioned the term disease-modifying. Could you tell the website audience what that means?
Sure. Disease-modifying drugs are the drugs that will change how the outcome of the disease is going to be. One of the key concepts in rheumatic disease right now is that with uncontrolled disease, over time, the damage index, however you wish to determine and define a damage index, continues to go up at a relatively constant slope. If you if you intercede with a disease-modifying agent, you change the slope of that damage index so that over a period of time, instead of having more and more damage and being a more and more dependent member of society, you can keep the child functioning at a higher employable working level. And when we actually look at what happens to the children now, they tend to come out above average. They do very well in their social and in their economic outcome. They're a little bit more focused because they're not out there as much as the others, and they do very well.
What kind of medications are you talking about?
Virtually every medicine that's used by adult rheumatologists is used by experienced pediatric rheumatologists. Long ago, we used to have to worry that they hadn't been specifically tested in children. But if you held back until every drug that we use in treating children had been specifically tested in children, you wouldn't be able to give them any of the latest therapy. And you're depriving these children who are growing and at the stage where their joints are the most vulnerable to long-term deformity of the best possible medicine. So right now, we go through everything that's available for adult rheumatology, and in the appropriate child, with very careful monitoring, we use those drugs, and we're getting excellent outcomes.
That includes what medications specifically?
That includes all of the non-steroidal anti-inflammatory drugs. For severe arthritis, we use a lot of sulfasalazine. Methotrexate is routinely used in pediatric rheumatology. Enbrel, the new biologic modifiers, is being used. Kinneret's being used. All of these drugs now, especially with the new emphasis by the FDA on pediatric approvals, have been tested in children, and although we don't wait for the official results to be out, we wait till it's been proven safe for children, we then can show that these are very effective drugs and we can alter the outcome for these children.
Let's move to a different disorder, systemic lupus erythematosus. Do the children present in different ways than adults with that disorder, and how do you treat them?
Children with systemic lupus are a very important subgroup. As you know, we have a big center for children with systemic lupus erythematosus here, and tremendous experience with that disease. Sometimes they present explosively, but far more often they present as that childhood or their adolescent failure to thrive. A child who's just not doing well, seems to be withdrawn from school, isn't acting right, seems a little depressed, losing weight. Sometimes they're having rash, sometimes they're having fever, but often the family doesn't really recognize that that rash and fever are coming from lupus. They don't know what they're coming from. And often they have arthritis, but the family won't recognize it. The kid just hurts all over. Once we see those children, they get started on an appropriate low dose of corticosteroids. Many of them get much better with just an appropriate low dose. When they don't, when it appears they're going to require moderate or high dose steroids for any period of time, then we switch them over to immunosuppressive therapy with consistent use of systematic intravenous IV cyclophosphamide. We have a large number of children who had biopsy-proven diffuse glomerulonephritis who now look normal. They're off medications. They're productive young adults on no medicine at all with their family. They're not Cushingoid. They don't have avascular necrosis. All of those long-term steroid side effects that cause so much morbidity, we can avoid by getting them off the steroids and onto appropriate immunosuppressive drugs. We've been extremely successful in keeping those children so that instead of saying, I hate it, doctor, the steroids gave me acne, the steroids made me fat, the steroids gave me stretch marks, they come to us when they're on the IV Cytoxan and say, I don't even remember that I have lupus except when I have to come to my doctor's appointments.
How important is the partnership between the child, the parents, and the physician in defining a good outcome?
It's crucial. You have to have the faith of the child and you have to have the faith of the family in the physician. A treating team of physician, parent, and child working together is going to get a good outcome. If you have 3 poles, each pulling in a different direction, you can't go anywhere. Whenever you're working in pediatric rheumatology, one of our key things is we recognize we're dealing with children who don't necessarily have the same attitude towards illness and responsibility as adults have. We're dealing with parents who may have conflicting opinions about what should be done for a child and not a complete understanding of the importance of the medication. And we're dealing with ourselves. Pediatric rheumatologists are primarily educators. We have to educate that child to know what to expect and how to respond. We have to educate the parents so that they believe in the therapy that we're giving to their child. And when the 3 of us work together, then we can get an excellent outcome. If one part of the team is running off in another direction, it's never going to work out as well. And one of the big important aspects of being a pediatric rheumatologist is knowing you have to be the coach, you have to nurture the team, you have to keep the team together. That's very different from being an adult rheumatologist where it's just you and that patient. I have to keep dad in the picture, I have to keep mom in the picture, I have to keep the patient believing in what we're doing, and I have to worry about what grandma's saying at home.
Things have gotten so much better, but they clearly need to go further. What can the people out there expect for the future with regard to progress?
We've made tremendous progress in pediatric rheumatology over the past 20 years. I've been doing this 25 years now, and having started off walking into clinics full of children in wheelchairs, we've virtually banished wheelchairs from this hospital. I think the thing to understand is the biggest obstacle right now is there aren't enough pediatric rheumatologists, and there's too many children who aren't getting to care soon enough in their disease. They're being dismissed as having growing pains, dismissed as having a minor injury from sports, and not getting to the physician soon enough to fix the problems. If they get to us early, we can put out the small fires and we can get excellent results. If you come to us after you've had arthritis for 10 or 15 years, we're going to replace your joints and make you functional again, but we can't restore you the way we can if you've early in your disease. We get you the proper therapy. We make you a good, perfectly functional adult.
Thank you very much, Dr. Lehman.
Thank you, Steve.